I'm Dr. Paul Shyn here with Dr. Dan Souza, and we're going to present safe and successful kidney parenchymal biopsies, what really matters.
Hi there, I'm Dan Souza. Dr. Shyn and I have no relevant conflicts of interest or financial disclosures.
By way of introduction, the historical evolution of kidney parenchymal biopsies influences how these procedures are performed today. Therefore, historical approaches that may or may not remain relevant in a modern interventional practice will be considered and critiqued. Many case examples of image-guided kidney parenchymal biopsies will be presented to illustrate current technical strategies that maximize diagnostic yield and minimize complications.
So first and foremost, before proceeding to the biopsy, we want to make sure that there is an appropriate indication relative to the risk of performing the procedure. And usually the nephrologist is actually the physician in best position to determine if a renal parenchymal biopsy is likely to impact patient management. Kidney parenchymal core biopsies, they carry more bleeding risks than an FNA biopsy or non-visceral organ core biopsies. In the literature, it is estimated that major complications can occur in between 1 to 7% of cases. But in most busy practices like ours, the complication rate is probably in the range of 1 to 2%. There are some risk factors, though, that may increase that risk, including older age, renal failure, hypertension, thrombocytopenia, anemia, the larger number of core passes, and obviously use of anticoagulants and other coagulopathies. Most of these biopsies are performed in a hospital setting or in a center that is close to an interventional practice. We do check some lab parameters. How well these lab parameters stratify bleeding risk is uncertain, but we do take them into account. We want to manage anticoagulants, but evaluating the risk and benefit. Whenever possible, we do want to withhold anticoagulants to decrease the bleeding risk. There are other considerations. We know that renal dysfunction and renal failure is correlated with platelet dysfunction, particularly when the eGFR is less than 30. And a lot of people advocate the use of desmopressin or DDAVP within 1 hour of the procedure to improve platelet dysfunction, although some recent meta-analysis have shown that this is not corroborated by data. Severe hypertension is also thought by many to represent an additional risk factor, particularly when the systolic blood pressure is greater than 160. Severe anemia, some believe that, especially when the hemoglobin is less than 10, it increases the bleeding risk, but most importantly, it decreases the patient reserve. So it's helpful to get this addressed before the biopsy. We also want to finally review the entire history, imaging, allergies, comorbidities, and prior procedures. Intravenous conscious sedation is not mandatory, but recommended, and we use it in our practice. It is helpful to manage patients' anxiety, and it can also cause some amnesia after the procedure, which can be helpful. It mitigates pain, and we use fentanyl for that purpose. We usually sedate before the final skin marking so that it allows some time for the patient to get a more predictable breathing pattern. There's a fine line between not sedating enough and sedating too much, because if you sedate too much, the patient starts snoring. Heavy breathing can cause some unusual breathing patterns, and the kidney can move a lot during heavy sedation. We do give local anesthetic, 1% lidocaine, into the skin, the subcutaneous tissue, fascial planes, particularly the peritoneum and the intercostal tissue. It is our personal preference to avoid injecting lidocaine into the organ capsule. IV conscious sedation is usually not necessary for the transplant kidney biopsies.
It's important to know your biopsy devices. Most of the core biopsy devices used are semi-automatic, meaning that the inner stylet or tray is manually deployed and the outer cutting cannula is spring-loaded and fires when you press on the handle. Some are full core end cutting type needles, such as the Biopens. I've used it a few times. I'm not a fan. It seems like I've noticed more bleeding with it, but some people like it. Be aware of how your introducer tip is configured, whether it's beveled or a diamond tip. The beveled needles have a bit of a cutting end, and they tend to drift a little bit away from the face of the bevel. The diamond tip pushes through tissue nicely, and it tends not to deflect. Make sure you get a core biopsy set that's long enough so you don't come up short. We like the single stick approach using a 17-gauge thin wall introducer and an 18-gauge coaxial core biopsy needle. We use a one capsule stick approach and get typically 2 maybe 3 samples through that one stick. Keep in mind, you can rotate the slot or the trough of the core biopsy needle in the desired direction where you think there's more glomeruli. Or if you take 2 or more samples, you can rotate the slot into a different direction for each sample. And then tipping the introducer needle before firing can help get better core samples. What I mean by that is when you insert the core biopsy needle into the patient's body, the body wall acts as a fulcrum. So when you push the handle in the direction opposite of where the tray is facing at the other end of the needle, it will push the tip of the needle in the opposite direction. And that has the effect of compressing tissue into the slot, and it tends to give you better core samples. When we do core biopsies of the kidney, there's a little bit of controversy about the gauge to use. Some advocate using larger gauges. We've been very satisfied with the 18 gauge core biopsy needle. I can tell you that the pathologists initially were pushing us to use larger ones. I think that was based on their experience with nephrology. But if you are consistent in getting cortical tissue and not medullary tissue, 2 18 gauge core biopsy samples are usually very sufficient for their purposes, and they tend to be very happy with these samples. Using ultrasound or CT guidance, both are acceptable. I would point out that CT has some advantages. For example, in large patients where visibility may be limited with ultrasound, CT certainly can be helpful. But the other thing is that when you use CT, I feel that it gives you a much larger range of possible approaches for optimal cortical targeting. And it can be done with minimal radiation dose. So it's certainly reasonable to use ultrasound or CT. And either way, we're going to use the same technical guidance. Positioning is obviously going to be prone or decubitus or oblique. And then breathing is something that we take into account. Usually, rather than giving breathing instructions, we just watch the patient's breathing and try to do our maneuvers in end expiration.
On-site assessment of the specimens by the pathologist is very helpful, and we have that in our practice. We like to place the core specimens fresh on a wet TELFA pad so we can inspect them more readily. Those core specimens are assessed by a pathologist, a nepropathologist, using a dissecting microscope. And really, the core specimens are all about the glomeruli, with very, very rare exceptions. All they want to know about is how many glomeruli they have in the specimen. They're not very interested in looking at medullary tissues. It's very rare for them to need medullary tissue and to make a diagnosis. If you don't have an on-site pathologist, consider getting a dissecting microscope and getting used to inspecting the specimens for the presence of enough glomeruli. Those specimens are sent for light microscopy, immunofluorescence, and electron microscopy. As Paul said earlier, usually 2 to 3 cores are more than enough for a diagnosis. If you frequently require more than 2 to 3 core samples, you should probably reconsider your technique.
In terms of which part of the kidney to target, the conventional approach has always been to target the lower renal poles to avoid hitting the collecting system or large blood vessels, or to approach the kidney along Brodell's avascular zone. But it's important to understand that there are historical reasons for this. One is that kidney parenchymal biopsies were often in the past performed blind, or the patient was marked with ultrasound and then sent for the biopsy. Also, these approaches are more relevant to surgical procedures or even percutaneous nephrostomy procedures where the expectation is to cut or puncture into the more central portions of the kidney. So for us, doing cortical biopsies, there's really a better approach. If you look at this schematic cross-sectional image of the kidney, imagine this is a patient lying prone on the table. This is a CT cross-section of the kidney. The anterior part of the kidney is on the bottom of the slide. If you bivalve the kidney along this line marked by the blue arrows, and then from the center of the kidney, draw an angle that's about 15 degrees posterior, this is Brodell's line. And you can see that it goes through a somewhat more avascular plane of the kidney. And it makes sense to use that plane if you're going to cut into the kidney deeply or place a nephrostomy tube. But if we're going to stay in the cortex, that becomes irrelevant. If you look at this diagram on the left, I like to think of the renal hilum, and sinus regions as the red zone, where we absolutely do not want our needle to go. The medullary pyramids are in this yellow zone. And notice that even around the medullary pyramids, you have fairly sizable arcuate and intralobular arteries that we would rather not hit. So if you stay away from the medullary portions of the kidney, you'll not only get less irrelevant medullary tissue, but you'll have less bleeding. And instead, we want to focus on the green zone here, which is the cortex itself, right under the capsule. And if you look at an arteriogram, as shown on the right, notice that whether you're at the upper pole, lower pole, interpolar region, the cortex has similar hypovascular distributions of blood vessels. And the larger blood vessels are much more central. So as long as you stay in the cortex, it really makes no difference whether you're at the lower pole or interpolar region. So we're going to aim for the cortex. In choosing the approach, we want to choose an approach that keeps the entire needle path only in the cortex. We could go upper, mid, or lower kidney. The interpolar region is fine. We are not going to enter the renal sinuses or hilar regions. We're not even going to enter the renal medullary pyramids. We're going to try to stay about 1 to 4 millimeters inside the capsule. I would say not more than 5 or 6 millimeters inside the capsule. And we're going to avoid renal cysts, obviously, but be cognizant of cortical scars and areas of thinner cortex. There's no point in targeting these areas because the yield is going to be lower. So look for areas with thicker cortex. Choose, of course, an unobstructed path to the kidney. Plan an eccentric or almost tangential approach to the kidney cortex. Make sure the needle does not point at the renal sinuses or hilum. And again, choose thick cortex, preferably with a somewhat flat surface, and I'll show you what I mean by that. Now, when we describe this tangential approach, it's important to know that we're certainly not the first to describe this. This nice paper from 2010 by Patel and colleagues very nicely describes the tangential approach. I think that what's interesting, though, is that this tangential approach is not that widely appreciated. It's worth revisiting.
So if you're using ultrasound as a modality to target the kidney and you want to remain tangential, it's helpful to use a sagittal plane, in which case you can actually choose to target the lower pole. That way you're able to remain tangential and only get cortical tissue. In transaxial plane, if you're using ultrasound, you want to consider the interpolar location so you can remain eccentric in targeting the cortex. On CT, you want to try to avoid the tip of the lower pole, and you want to try to remain using an eccentric approach, tangential approach, when you're targeting just the cortex.
I like to think of the shape of the kidney as sort of reminiscent of the nose cone of a Boeing passenger jet, like a 707. One of the things you'll notice is that the shape of the nose is a bit faceted. It's not perfectly oval or perfectly round. And as we take cross-sections going from the interpolar region to the lower pole, of course, the cross-sections get smaller. And notice that the closer you get to the lower pole, if you're doing a tangential approach, the length of cortex you can sample becomes shorter. And at the lower pole, it's quite short. So again, the cross-section of the kidney, like if you remove the nose cone of the airplane, this is kind of what the kidney shape often looks like. It's not perfectly oval. It has a little bit of a faceted shape. And so there are often flatter surfaces that you can choose to target that give you a nice tangential approach and a reasonable length of cortex to sample without diving into medullary tissues. So for example, here, if you go at the lower pole using CT, part of the problem you have is averaging. It can be quite difficult to know if your sample is in the cortex, in the medulla, or even sliding off the tip of the kidney. And if you look at the coronal reconstruction on the right, you can see that the amount of cortex that you can sample at the tip is actually relatively small.
So a few examples. In this case, you can see how the needle is a little bit too central. Although you may think you're in the lower pole, in the edge of the lower pole, because of volume averaging issues, this was actually a non-diagnostic specimen. And a better approach would have been the orange arrow, remaining in the flat surface, close to the capsule, the entire needle within the cortex. So when we evaluate the best location to proceed, we want to consider areas where the kidney is flatter. We want the tangential approach, and you want an area where the cortex is thick and relatively flat. So this is an example here. On this case, we would probably go on the left kidney, tackling the posterolateral cortex of the kidney. You want to make sure you have enough length so that the entire needle path is within a few millimeters of the capsule, not going through and through the capsule. This is another example. You may think that in the first image on the left, the cortex is quite flat, but unfortunately, it seems a little bit thin. So you want to avoid an area where the cortex is too thin because the diagnostic yield is going to be lower with fewer glomeruli in that region. On the other spectrum, if you go in the lower polar, you've got probably a little bit too low, and you don't have enough renal parenchyma to be able to have the entire length of your tray within the kidney. So probably a better option would be the middle image, where you have the cortex that is relatively flat, or at least flat enough so that your needle can remain within the cortex, and also the cortex is much thicker. So we proceeded to perform the biopsy in that location, and you can see how the tray is within a few millimeters of the capsule and entirely within the kidney. And this was diagnostic with only 2 core specimens.
Here's another example. Notice that the one of the kidneys has many cysts, which kind of makes it a little bit tricky to do the biopsy. On the other side, we have fewer cysts, and there's a nice area of thick cortex, and we can choose a somewhat tangential approach, and that's what we attempted. What you can see on the left-hand image is that our needle actually entered the kidney slightly deeper than we had intended. And so when we initially deployed the stylet, the tray, as you see on the right-hand image, it was really about 6-7 millimeters or 8 millimeters from the capsule. And this actually was medullary tissue. So to salvage the situation, what we did here, there are a couple things you can do. One is on the next sample, point the needle more laterally towards the capsule when you deploy it. But we also bend the tray a little bit before we put it back into the introducer needle so that when we deploy it, it tends to deflect towards the capsule. And then once it deflects towards the capsule, as it does here, we rotate the tray so that it's facing the cortex. And we took 2 samples here and had very good cortical tissue. Another example, choosing it on the planning image, an eccentric approach where the cortex is relatively thick and no critical structures in the way. As we approach the capsule, one thing to realize is that anytime you're approaching a capsule like liver or kidney with a needle and you're coming at it somewhat tangentially, sometimes the needle will slide off the capsule or tend to deflect a little bit. And so there are 2 things to do to kind of avoid that problem. One is when you're near the capsule, when you're ready to go into the kidney, use a quick jabbing motion or stabbing motion to just pop the needle into the kidney. And sometimes I'll even just tip the needle, point it slightly a few degrees into the kidney so that it will be sure to bite into the capsule, and then resume my original angle inside the capsule. That's what we did here, and we got nicely into the cortex, and we got 2 cores and a diagnostic specimens.
Another example now with ultrasound guidance, you can see that with ultrasound, you have 2 options. You can use a transaxial approach, a transverse plane, and you can also use a sagittal plane. On the left side image, you can see that the dotted line shows an approach that is probably not ideal, as the trajectory of the needle is a little too deep and not close enough to the capsule. So a better approach would have been the dashed orange line, which shows a trajectory that is a lot more eccentric, more peripheral, much closer to the capsule, which is our goal. On the sagittal plane, the biopsy ended up being performed in the sagittal plane. You can see a nice trajectory, an entry that is almost tangential to the capsule, and the needle is entirely within the cortex. So this was a diagnostic biopsy. A few tips. It's important to maintain purchase. You want to make sure that the introducer needle remains within the kidney, at least 5 millimeters inside the cortex. And in order to do so that we maintain a single puncture approach, you may want to advance the introducer needle over the core biopsy needle between the core specimens being obtained so you don't lose that purchase. And you can make sure the needle remains in the kidney by observing the motion of the needle as the patient breathes. Do not press the tissue of the core specimens onto the TULFA pads. You want to just roll the core specimen onto the TULFA, and in order to avoid the crush artifacts on the histopathology. You also want to tackle the lateral aspect of the kidney whenever possible, which is less likely to have accessory arteries when compared to the medial aspect of the kidney.
This is a patient, a 36-year-old female with hematuria, proteinuria, who needed a parenchymal biopsy. And as the needle entered the kidney, the angle was a little bit deeper than initially hoped upon entry. You can see on the dashed line. So the stylet was once again bent and deployed, also with tipping of the needle pointing more towards the capsule to get the tray in an optimal position. We got diagnostic core biopsy specimens here. And on the post image, there was only a trace amount of perinephric blood. This was a 54-year-old female with Hodgkin's and acute renal failure with an eGFR of only 7. We were able to find a nice approach here between the ribs, not too close to the undersurface of a rib. We had plenty of length in the cortex to place our needle and maintain purchase, and then got 2 diagnostic core specimens here without a bleeding complication.
This was a 22-year-old pregnant woman that had a suspected minimal change disease that was referred to biopsy by us. You see how the planning is very appropriate. You see the trajectory that was planned was very peripheral, close to the capsule. But the issue here was that the needle tip was parked at the level of the capsule for too long, and the bleeding actually started before the tray was even advanced. Even a core biopsy was obtained, the patient already started bleeding. You want to try to avoid parking the needle and having the needle tip sit on the capsule for too long. You want to make sure you pop into the kidney and you have your needle located along the cortex, not along the capsule. This was a 45-year-old man that was referred to an ultrasound-guided biopsy. He was on Lovenox for PE. You can see how ultrasound can be challenging sometimes. The first approach, the image on the left, shows a lot of rib shadowing obscuring the kidney. We were able to find an adequate plane using ultrasound and an oblique image. You can see how the yellow arrows are kind of outlining the kidney, but it's still a little bit difficult to delineate with precision. And on that image, you can see how the needle is a little bit too deep to the capsule, maybe not peripheral enough, and this patient ended up developing a large hematoma post-biopsy. And this was a 36-year-old woman that had low plates of 117 and eGFR 17. You can see the biopsy needle is parked a little bit too deep into the kidney. Although it is in the lower pole, you can see the needle is probably over a centimeter deep to the capsule. And this patient ended up developing a small hematoma. Another example, a 41-year-old woman with recurrent hematuria and proteinuria that ended up having IgA nephropathy with active inflammation. The biopsy needle is actually too deep. You can almost see the tray coursing throughout the more hypodense medullary of the kidney. And a more medial approach probably would have been better, where you can see the dashed lines kind of with a trajectory along the cortex. And this patient also developed a small hematoma.
This is a 51-year-old man that had renal failure and underwent renal parenchymal biopsy with ultrasound. Again, on the left image, the blue arrow points to the needle that's going into the kidney. And this one is really pointing right at the kidney and even towards the renal sinuses. A better approach would have been, as shown on the right-hand image, by the orange line coming eccentrically into a polar region of the kidney. This patient did develop a painful hematoma after the biopsy. Another ultrasound-guided parenchymal biopsy in a patient with alpha-1 antitrypsin deficiency and post-lung transplant. This was a transaxial approach. Again, the needle is right at the border of the renal parenchyma and sinuses. So on the left-hand image, that's too deep. A second pass was made a little bit more eccentrically, which was better, but there was still a small hematoma afterwards. This 66-year-old woman with DVT, breast cancer, hematuria, and acute kidney injury underwent renal parenchymal biopsy. You can see on the left-hand image, the core biopsy is obtained with the ipsilateral kidney down, and the core slot looks like it's in an area that's kind of flat, almost looks scar-like. Actually, in retrospect, looking at a CT scan from 4 years earlier on the far right, you can see that there was a cortical scar in this location. So that might not have been the best target area to choose. Also, areas of thin cortex bring you kind of closer to the more central vessels, and maybe that's why this patient developed a large hematoma as shown on the middle image.
Biopsy of a renal transplant is actually easier than a biopsy of a native kidney. And ultrasound works very well for these biopsies because the kidney is very superficial and fixed in position. So that way, it's very easy to plan the approach that keeps the needle in the cortex only. The other advantage is that the transplant kidney itself is not pain sensitive for the patient, so patients tolerate it a lot better. This is an example of a procedure performed with ultrasound. There are a few options. You can use a long axis and targeting the cortex in an oblique approach, remaining tangential and close to the capsule. Or you can use a short axis approach, always remaining tangential and close to the capsule, as in this example on the right. In this example, 30-year-old female patient with lupus and hypertension. She had a transplanted kidney, and unfortunately, the biopsy was actually targeting directly into the renal sinus and not remaining tangential or peripheral, as we just discussed. And this patient developed a very large hematoma. You can see the CT images, the large hemoperitoneum surrounding the renal transplant. And ironically, you can see on the CT that there were very good options to target the renal cortex tangentially, coming from a right lateral approach or even an anterior approach, remaining peripheral and close to the capsule. One additional tip is always try to avoid including the renal capsule in your core needle slot. You want to make sure your entire needle tray is within the kidney.
At the end of the procedure, I always look to see if there's back bleeding from the introducer needle. If there is, one approach is just to leave the introducer in place with the stylet in or partially in for about 5 to 10 minutes and just let it clot off. You can push the clot in if you want. You can back it out a few millimeters at a time and then just see if the back bleeding has stopped. It's kind of analogous to just holding pressure on the puncture site. Some people use gel foam, and now we have even RF track cautery available. This was a 27-year-old man with proteinuria hematuria, and we did a renal parenchymal biopsy as shown on the second panel. We got a cortical sample. We noticed that there was quite a bit of back bleeding, so we put the RF cautery electrode in, cauterized the track, and then the post image, you can see there was no bleeding.
So after the procedure, the minimum post-procedure observation is typically 2 to 4 hours, and you can extend that time if you have any concerning issues. During that time, we obviously will monitor the vital signs, monitor also the patient for any pain or other symptoms like significant hematuria, any swelling or bruising at the puncture site. And if the patient is still in the observation suite, you want to maybe check the hematocrit at 6 hours to make sure that there is no ongoing bleeding. Historically, these procedures used to require overnight admission, but using the technique that we just described, being there very tangential, close to the capsule, with remaining in the cortex, that admission is usually not necessary. And obviously, you want to give the patient instructions prior to discharge.
I thought we would finish with a word about teaching this approach to your residents and fellows. One thing that I've found is simply explaining the approach or giving a talk doesn't seem to be enough. It's something that really requires a bit of proctoring, supervising, sort of a hands-on training to get people to really appreciate how to apply this technique successfully. Even reviewing prior kidney parenchymal biopsy cases and the outcomes from those cases can be helpful. But basically, when you're doing a case, when you get your planning scans, whether it's ultrasound or CT, if it's CT, scroll through all the slices through the kidneys, look at every slice, and you can kind of discuss with the trainee the pros and cons of the different approaches, possible approaches. One thing I find, whether you use ultrasound or CT, renal parenchymals really deserve a few extra minutes of planning the approach, and it will save headaches and help you have a successful procedure. So with that, Dan, I think we can thank everyone, and I appreciate your participating once again in these talks, and hopefully this will be helpful for everyone.
Thank you, Paul. Thanks everyone for listening, and please don't hesitate to reach out to us.